Welcome to the Neuroveda podcast for complex health. We feature expert guests who dive into ancient and cutting edge understandings of health and disease. These conversations are about food, lifestyle, and medicine just as much as about nature, culture, and politics. I'm Jillian Ehrlich, family nurse practitioner, certified in Ayurveda and functional medicine, coming to you from our clinic, Neuroveda Health, in Seattle, Washington. And I'm really excited to introduce a dear friend of mine and colleague, Dr. Tania Dempsey. She's an MD and ABIHM. She's a world-renowned expert in complex multi-system diseases. As the founder of AIM Center for Personalized Medicine in Purchase, New York. Dr. Dempsey uses functional and integrative medicine to get to the root cause of illness and to help find the path to optimum health. Her extensive knowledge and experience with mast cell activation syndrome, mold, and Lyme and other vector-borne diseases has propelled her to the forefront of the medical community as a recognized and trusted speaker, researcher, advocate, and physician. She is board certified in internal medicine and integrative and holistic medicine. She received her MD degree from the Johns Hopkins University School of Medicine and her BS degree from Cornell University. She completed her internal medicine residency at NYU Medical Center. She was recently elected to the board of director of ILADS, the International Lyme and Associated Diseases Society, which we will talk a little bit more about. And she's also a member of the US ME/CFS Clinician Coalition, the American Academy of Ozone Therapy, and ISSWSH, which is the International Society for the Study of Women's Sexual Health, as well as MCAS, the International Society for Mast Cell Activation Syndrome, which we work on together. She's an accomplished super fun. She's an accomplished international speaker, writer, and thought leader, has 8 peer-reviewed articles in the medical literature, and her latest endeavor is co-hosting the new podcast, Mast Cell Matters. You can find out more about her and her work at her website and at the Mast Cell Matters podcast site. I'm going to ask you those in a minute, but I just want to end this by saying at the heart of Dr. Dempsey's work is a commitment to patients who've long gone unheard. I think that is so remarkable because at the end of all of your training, what it comes back to is listening to the patient. So I love that that really encapsulates kind of who you are and how you practice. So welcome, Tania. We're so happy to have you. Please tell us right off the bat where people can find you.
Oh gosh. Okay. So website is drtaniadempsey.com. Of course, the podcast on all podcast platforms is Mast Cell Matters. And then Instagram is Dr. Tania Dempsey MD. And I think Facebook is Dr. Tania Dempsey. YouTube, I think I have Dr. Tania Dempsey. So, I mean, if you just Google my name, I think those things come up, hopefully.
Okay, perfect.
But I love, getting content out there for education. Like education is really my mission right now. So I'm doing a lot.
Good. Well, case in point, here we are today talking about Lyme disease. So let's dive in. And we're going to start kind of broad and then kind of get granular. So what is Lyme disease? What are the co-infections?
So Lyme disease is really like, I take a deep breath. Like, okay, here we go. Because if you know me, I talk very fast. So for the next 15 minutes, Lyme disease is really one infection known as Borrelia burgdorferi, caused by that organism, Borrelia burgdorferi. It's a bacteria. The truth of the matter is that Lyme disease is really just one of many infections that can be transmitted by various vectors. Borrelia burgdorferi is transmitted by a tick. There are lots of cousins of Borrelia burgdorferi in the Borrelia category where they can be transmitted by different ticks in different parts of the country. We think of Lyme as more endemic to the Northeast, but we know it's spreading. And we know that there are cousins that live basically all across the world and across the country. So the co-infections really, I think that's a misnomer. I really think that they should all just be called vector-borne infections because they all can present alone or in combination with others, because the vectors that are transmitting things, which are usually other types of insects, so the ticks can transmit a bunch of them. Then you have things like mosquitoes, biting flies, ants, lice, fleas, the list goes on. There are lots of these things that transmit different types of infections. And then you have things even like spiders, and then bites or scratches from mammals that are carrying these things. So like cats and dogs and other mammals can carry things like Bartonella, which is one of the other infections that's vector-borne. So I no longer think of Lyme anymore as a Lyme used to be known as an umbrella term, let's say. We used to just say, "Oh, I have Lyme." And then many of us in this community would understand that they may have other infections too, but it was just easier to say Lyme because everyone may have heard that. I've sort of gone away from using that term because the reality is that I almost never see Lyme anymore alone. I never see Lyme exist in a person without anything else. It just doesn't happen. They have Lyme and Babesia, Lyme, Babesia, Bartonella. Sometimes they don't have Lyme. They have Babesia and Bartonella, or they have Ehrlichia, they have tularemia, or they have Brucella. I mean, there's just again, hundreds, thousands, maybe, things that can be transmitted. So I think of them as vector-borne infections that can coexist. Again, one or more together. They cause a variety of symptoms. There's definitely overlap between these symptoms. Some of them are a little bit more specific to that particular organism. And of course, there's some general symptoms that kind of are found amongst all of them. A lot of the symptoms are actually driven by the mast cells. And that's why there's similarity between the symptoms, because any type of infection sets off mast cells. We know that, right? We knew it during COVID, but we've known this for actually for a long time, that mast cells are on our defense mechanism for fighting off things in our environment. And so they've been doing that for millions of years, but we are, bombarded by a lot more these days. And so they're definitely a little bit more primed. And so when someone acquires these infections, the mast cells get activated. And so I think that a lot of the symptoms are actually being driven partly by the activation of the mast cell. So I don't know if I answered your question, but that was my way of sort of explaining generally what it is. But it's much more, obviously, much more complicated. And I'm happy to hone in on the individual infections and give you a little more, information.
Yeah. So when we talk about vector, right? So like in math or science, a vector is something that brings something to something else. And so what we're talking about in terms of a vector is like there's some intermediary. So there's the organism itself, and then there's a vector that brings it to you, and then there's you. Is that right?
That's right. That's right. So typically these infections are, let me give you an example. We know that a lot of mammals carry some of these infections. There may be other animals that carry, but let's just say in the wild, mice, rodents, deer are carrying, these various organisms. Then a tick or some other insect bites that animal, sucks the blood, acquires the infection, then goes and bites another mammal, and then maybe a human, and then same thing, like sort of injects the organism in, sucks blood, maybe acquires other things from the human for all we know, right? And then it bites something else, right? So this is that's vector. There's something that's carrying this infection basically from one animal to another. And the reason this is important is because there are lots of vectors, right? And there are lots of ways to have a vector introduce an infection into you. And so when I think of, really what's the leading cause of chronic illness in this country, it's infection. Sorry to say if others have other theories, but it's because we have not just these types of infections being transmitted via vectors, but we have, upper respiratory infections, right? Somebody coughs on somebody else. That's the vector, right? Transmitting it to somebody else. Just so easy to transmit infection in our population.
Yeah. Well, I mean, we are herd animals. We like to be together. We like to be close. I mean, that's a healthy part of being a human being.
Yeah.
So what's special or unique about these infections, like this group of infections, that makes it different than something like a common cold? I'm not going to say like COVID, we'll go there later, but something than like the common cold or pink eye, or what is different about these infections? And I'm just going to put in there like my small political rant, like University of Washington often will refuse to treat what they call chronic Lyme. So, there's a lot of infectious disease providers out there who don't recognize, won't recognize, or don't recognize chronic Lyme. And so can you talk to us a little bit about what's special or unique about these infections, and sometimes why are they not recognized or treated?
So, yeah, because the teaching in med schools and nursing schools and wherever you're getting educated in the medical profession, the teaching is that our immune system should be able to fight off infections. And if we can't fight off an infection, let's use an example of like strep throat. Okay. Strep, you don't really want to fight off on your own because it can lead to some very serious conditions, right? And back in the day before antibiotics, people died from strep. So you take an antibiotic and, presumably 10 days of amoxicillin or whatever gets rid of strep, right? That's the teaching. That's what we were taught, right? That it gets rid of it and then the person goes on and they're fine, right? Or if they get a virus, the flu, whatever, their body deals with it, the immune system kicks in, and they get rid of it. But what is not fully understood by many, many medical professionals, although it's in the literature and should be understood, is that many infections actually are not fully cleared by the immune system. And let's take strep again, for instance. Strep, if you have tonsils, and you get strep throat and you take antibiotics, presumably you've killed a lot of the strep off and you've treated the strep infection, but those strep bacteria can still live in the tonsil. They're not dead. They're not gone. Let's take, for example, during a strep infection, maybe there are 1 million strep organisms. You take the antibiotics and maybe you bring it down to 100 strep organisms. And at 100, you don't have a sore throat, you don't have fever, you feel fine. But there's still 100 living, right? And they can reactivate and then you can get strep throat again, right? So, those kids that keep getting strep throat and the doctors will say, oh, yeah, it's going around the classroom. Oh, yeah, they must have been exposed again 2 weeks after they finished their antibiotics. They weren't exposed again. That came from them, from their own body. That's strep reactivating. It was the strep that said, you didn't kill all of us, so we're gonna multiply and come back. And the reality is that a lot of infections do that, okay? But we've not really thought about this enough, I think, in the medical profession now. So we take these infections like Lyme, Bartonella, Babesi, other things. These infections are even more nuanced because they not only can they live even despite antibiotics or other treatments, they can persist in the body. They can evade the immune system in a way that we've almost never seen with other types of infections. So they have these mechanisms where they can change forms. They can become stationary, almost dormant, where the immune system doesn't see anything because it's not multiplying until then the immune system settles down and then all of a sudden it comes back out and starts to multiply. So there are these unique things that these infections do. Babesia lives in red blood cells. Actually, Babesia is a cousin to malaria. Malaria also lives in red blood cells. And now a lot of people think malaria is also treatable and you just take some antimalarial drugs and get rid of it. I know patients who have chronic malaria. No one believes them because it just doesn't seem possible because it seems like you could kill it all. But they live in the red blood cell, becomes a reservoir. Now your red blood cell carries oxygen, carries iron, right? There are a lot of things that red blood cells do. And the Babesia organism can get in there and can be dormant and everything's fine and no one feels anything. Then it comes out of the red blood cell, starts to multiply, starts to cause a number of symptoms. Some overlap a little bit with malaria. Malaria causes more of like severe fever and almost like rigoring and chills. Babesia will cause more like sweats, usually not a fever, occasionally low grade, but like a temperature spike that people feel. The temperature stays the same, but they feel hot, sweaty, palpitations, whatever, and then it can go back into hiding again. So when patients with these infections who have these sort of waxing and waning symptoms because of the way the immune system is dealing with it or not dealing with it or the way that that organism is living. Patients go to the doctor, particularly if it's a woman, okay? I have to say that because a woman with hot flashes and palpitations that come and go, and let's say that woman is like 45, 50, it's going to be
Yep.
immediately like, oh, you're getting old, you're going through menopause. And I'm not saying that they shouldn't pay attention to the hormones, because I talk a lot about hormones too, but it's just sort of like, they can't believe, that can't be an infection. That can't be what is causing this patient to feel this way. The patient must be crazy, depressed, or going through menopause, right? And so it's tricky. It's really, really tricky. Yeah. And so the reason chronic Lyme isn't believed is because they just can't understand, mostly infectious disease specialists just can't understand how an infection, how a bacteria can persist despite antibiotics. The patient took antibiotics, let's say, the infection must be gone. So what they have is post-treatment Lyme, like the sequela of the infection, not the infection itself. That's what they say.
And so it's one thing, like if you look at how effective an antibiotic can be for an organism in an active state in a petri dish where it can't really escape, but the body is so complicated and has so many kind of like tiny pieces you can climb into and hide. And so that's very different than the reality. So, okay, so we're looking at different locations, these infections. And I think my understanding is that a lot of these infections are very old. So something like, they're like, they've been around a long time. So they've kind of evolved alongside of us. And so they've they've essentially evolved a lot of evasive techniques. Is that right?
Yeah, I think that's true. They found that there was an Iceman in Northern Europe that I think 10,000 years old or 8,000, I may be wrong, but they found the Lyme spirochete. They were able, because he was so well preserved, they were able to find the Lyme spirochete. And there was some thought that he had some damage, I think in his joints or something. There was something that was like questionable about, maybe the Lyme was actually causing some damage, but he didn't die from Lyme disease, is what the bottom line is. So the question is, were they wreaking havoc back then and really causing major problems, or has it gotten worse? Have they evolved and become more aggressive, or have we as humans become less able?
Have we evolved? Have we gotten weaker? And so let's talk a little bit, because I think the other reason that it's often not believed is that testing is not great. So let's walk through, I think would be a good time to do an introduction to our different organisms. And if we could look at like, what is typical testing and what is the testing you recommend for kind of each family of organism?
So Lyme is probably the one organism that theoretically can be tested for through regular labs, but often the wrong test is done. And I have a new patient who is coming in who, the only thing they tested, and she has every symptom that I can see that's supportive of vector-borne infection. The only test was something called an ELISA test, which is a screening test for Lyme. It's just looking to see if there are any antibodies to Lyme. And if there are none, the test, everybody just stops there. The ELISA test is a very non-specific and not sensitive test. And so, a lot of doctors feel like if the ELISA is negative, we can end there. If the ELISA is positive, then the lab will do the next part of the test, which is a Western blot. And the Western blot then goes through the various antibodies, IgM, which are acute antibodies, IgG. And the same thing sort of happens. The patient might have one or two antibodies. They don't meet the criteria that the CDC says. You need 2 IgMs, you need 5 IgGs, either or. And then, the buck stops there. And people just think, okay, so the patient doesn't have Lyme, but I don't order ELISAs. I'll go right to a Western blot. Even the Western blot is problematic, but it could be a good screening tool. It sometimes is helpful, but you can have patients who are making a lot of antibodies. I'll call them like an autoimmune-ish type person. Could be a mast cell person who is spewing out lots of antibodies. And so I have these patients, they have like every band positive on the Lyme test. And others whose immune systems are so suppressed, they'll have no antibodies, but they have active Lyme. So really the best way, and just to say that the other infections theoretically can be tested in blood, but there's only usually like one strain of one type of organism. It's an antibody test. And again, because these infections evade the immune system is not going to show antibodies. So you need a molecular test. You need something that's actually going to pick up whether the infection is present in the blood. And so a FISH test is by far the best way to do this. And FISH is fluorescent in situ. FISH is fluorescent in situ hybridization. And the lab that we use actually uses a probe, and they are looking for the DNA essentially, or RNA of the infection. And the probe has a fluorescent stain. So if it finds the infection and binds, that fluorescent stain will light up, and they can look under the microscope and they can, oh, there's the bug. That's the best way to look for it, because it's either there or it's not there. All the testing that's been developed over the last, 20, 30 years or longer has been relying on our antibodies response to the infection. So, if we are looking for, even with COVID, the same thing happened, right? We were looking in the blood to see, oh, does somebody have antibodies to the COVID or not? Actually, there are a lot of problems with the COVID way of testing too. And the same thing holds true for this in a different way.
And so this is specific for Borrelia that you would recommend the fish testing?
I would recommend it for all vector
For all-
if possible. We don't have the ability to do fish testing for all organisms. We have the ability to do fish testing um, for Borrelia burgdorferi. We can do it for Borrelia, the genus Borrelia, which will pick up all those cousins to Borrelia burgdorferi. It will pick up something called tick-borne relapsing fever Borrelia, like Borrelia hermensi, Borrelia myomoti, and then there are a number of other Borrelias that are, let's say, found on the West Coast or found in other regions. Borrelia californescens, Borrelia Bavarianensis. There's all these other, and then there's European Borrelia of Zelli, Garini. The Borrelia fish could potentially pick those up. They won't be able to determine the exact strain, but it will say, oh, there's a Borrelia species here. You can do Babesia, the full genus of Babesia with all the strains. You could do one species of Babesia called Babesia otocoli. There's another lab that does the fish for, do they do the fish for? No, it's all general also, never mind. And then you can do Bartonella henselae. And the general, you could do a general Bartonella and then Bartonella henselae. Bartonella has at least 40, last I checked, I think it was 46 or 48 different species, 13 of which can infect humans. We have testing for like not even a handful.
Okay.
So we can't test for everything, but we do have the ability now more than ever to get a more definitive answer for patients. 5 years ago, 10 years ago, we were relying on empiric data, the patient's symptoms, their exposure history, etc. Now I need that, but I go right to the molecular testing because I really want to nail down the diagnosis, figure out which infections I'm dealing with, because the treatment will change depending on what we're dealing with.
And what is the name of the lab that you do the fish testing through?
So T-Lab is the main one. Igenex also is doing some fish testing as well. I think they're both great. T-Lab has the visual results and they send you the pictures, which is really cool. But Igenex sometimes can do things that, let's say, T-Lab can't. So those are the two labs we rely on the most. We do other labs too. Sometimes there are holes that we need to fill, and there are other labs that can help us fill those holes.
And what are those labs?
The other ones we use? Depends on what our goal is, but sometimes we use a lab called Vibrant. They have a tick-borne panel. Sometimes we'll use, let's say, Galaxy, or Galaxy is a little bit, in my opinion, a little more specific for Bartonella, and they're pretty good. for that. We've tried a number of other labs, and we've sort of kind of gone away from them, just haven't found them to be as useful as we would like. But I'm
Okay. Okay.
always trying to learn and always trying to get more information. And at our next Lyme conference, iLabs conference in October, I'm sure there will be other labs there, and I'll be exposed to more things, and maybe we'll try some, because whatever we can do to get, get answers, we need to do.
Yeah. So let's talk a little bit about let's talk a little bit about treatments. And I think it would be helpful if we could also go through those organisms again, and talk a little bit about the symptoms that might be specific. So, and we've done, me, Tanya. So we've done other podcasts on mast cell and on
Yep.
chronic inflammation and symptoms of that. So what we'll keep in mind is that all of these organisms can overlap in those chronic symptoms and how they trigger the immune system. But, let's kind of
Oh,
focus in
okay.
on the specifics for each. Like, what's helpful for me to remember these organisms is, like, I pretend like they're people with a personality. Like, one is your
Yeah.
annoying uncle, one is like, so, like, how do you think about the personalities of these different organisms?
Yeah. I think of Lyme as more like joint pain. I think of it as like causing things like tendinitis, inflammation, more musculoskeletal, although Bartonella, and I'll talk about Bartonella, has some overlap with that as well. Lyme can cause, you can get neuroborreliosis or Lyme in the brain, which can cause a whole host of very, very significant neurologic sequelae, including what looks like dementia, cognitive dysfunction, ADHD, can cause, I've seen seizures, I've seen depression, but that overlaps with these other infections, which can also cause a lot of neurologic symptoms. Lyme can invade the heart, so you see you can have Lyme carditis, inflammation in the heart. So yeah, I mean, the list is very, very long, but I think of those things maybe like more specific. Achy, headaches, acutely, like it's going to be more that flu-like. Then it just evolves, fatigue, etc. Bartonella does overlap somewhat with some of the musculoskeletal stuff, but with Bartonella, I might see more like soles of the foot or even the whole foot, like pain, discomfort. Doesn't make sense. There's nothing specifically anatomically wrong, but people complain of more foot pain. They can have shin pain. I've seen that sometimes with Lyme, but more frequently with Bartonella. Pain, general pain is a hallmark
Mhm.
feature of Bartonella. Patients
Mhm.
often, I have a number of patients who are on pain medications chronically because of this sort of systemic pain. Some
Mhm.
of it resembles fibromyalgia and some of it doesn't. It actually doesn't even make sense. It's not a specific area. It just is, significantly painful. A lot of neuropsych symptoms we see as well with Bartonella. Schizophrenia has been shown to potentially be caused by Bartonella. We know that severe depression. I think of things like PANS and PANDAS, autoimmune encephalopathy, as very much, it can be caused by all these bugs, but Bartonella is a little more severe. I think of it in OCD and those types of symptoms. Bartonella can cause a lot of vascular issues. It has a propensity to invade.
Mhm.
Bartonella also lives in red blood cells and
Mhm.
has a synergistic relationship to Babesia in those red blood cells. But after Bartonella goes into the red blood cells, it invades through the vasculature, and then into the
Mhm.
tissue. But it can cause a localized inflammatory reaction in the endothelium of the vasculature. And so it can cause various, let's say, vasculitis. And I've seen things like high blood pressure caused by Bartonella. I've seen um, it's been actually described in endocarditis, so infection in the heart.
Mhm.
Also, I'm probably forgetting things, but like that is kind of like the hallmark stuff of Bart. Babesia is, as I described before, a little bit more waxing, waning. typically has a time of day that it seems to be most active. It's different for everyone, but late afternoon is not an uncommon, or or at night, not an uncommon time to have an uptick in symptoms, palpitations, heart racing, sweating, or heat intolerance, brain fog. They all can do that. Headaches, they all can do that. Migraines, they all can do that. So those are the basic, basic stuff. Symptom wise, right? Those are the big three. Now, there are other vector-borne infections, but I like to concentrate on these three because I think these are the ones that we could test for. And these are the ones that I think are most pervasive. Okay, so when we think about treatment, Borrelia burgdorferi or Lyme and Bartonella are bacteria, and Babesia is a protozoa. It's a parasite. It's a blood parasite. So they are all going to be treated differently, but maybe you can argue that Bartonella and Lyme are bacteria, but they respond differently to different antibiotics. If you're going down, we'll talk about antibiotics first, just because it's just easier, because that's what people are most familiar with. My hope is to use less and less antibiotics, and I've already achieved a lot of that in my practice, but that's not to say that they aren't sometimes helpful. For Babesia, we're looking at more antiparasitic type drugs, antimalarial type drugs. I use a lot of herbs, a lot of Chinese herbs and other herbs too. Babesia can respond very well to things like artemisinin, cryptolepis, a number of them that we'll use in combination with antiparasitic or antimalarial drugs. Lyme exists in different forms. There's like a cell wall form, there's a spore form, there's a spirochete form, there's an L form. It's ridiculous how much this organism can change shape. And in the different forms, they respond differently to different antimicrobials. And that's the challenge. And so, sometimes you'll use doxycycline or minocycline, but then you have to layer cephalosporins, and then you have to layer spore form treatments like Flagyl or tinidazole. Then you have to layer, something else. But most patients have these multiple infections. So then they're on 5, 6 different antibiotics, and it's really, really complicated. Bartonella tends to respond to, it responds. The question is really, are they being killed, right? A lot of antimicrobials we're using are bacteriostatic, not bactericidal. And the difference is bacteriostatic means that it's kind of slowing the replication process of the organism. And in that way, it is killing some, but it's never going to kill all. And bactericidal kill, there are very few oral antibiotics that are bactericidal. And so a lot of times we're just suppressing. That's why patients stop things and they recur. So for Bartonella, though, in the literature, people are using things like a macrolide, like azithromycin or clarithromycin with rifampin or rifabutin. Now we know with more recent research that methylene blue combined with those has better penetration. And then maybe a TB drug called pyrazinamide. And of course, now there's a published protocol called the Dapsone protocol, which is a 9-week protocol developed by Dr. Richard Horowitz, who's a good friend and mentor. And he developed this protocol to try to limit the amount of antibiotics people have to take and the amount of time they have to take it. But it's a very aggressive regimen that includes a lot of the antibiotics I mentioned, and with the addition of a drug called Dapsone. And Dapsone is a interesting drug that has used for some more rare conditions. Dapsone is used for a infection called leprosy. It's also used in the derm world for some unusual type rashes, but it's anti-inflammatory, has some mast cell stabilizing properties. And this Dapsone protocol requires escalating dosages of Dapsone along with these combination of very powerful antibiotics, with the hope that by combining persister drugs, these are drugs that are targeting those persister bacteria that are not dying with the regular antibiotics. So Dapsone is a persister drug, methylene blue is a persister drug, pyrazinamide is a persister drug. You combine these things, and then maybe you really do kill those persisters, and then and the suffering. I think it does work for some people. We've had some successes for sure, but it doesn't work for everyone. And mostly what we see is the persistence of Babesia and probably also Bartonella, and people relapse. And so the things that I've turned to for treating is I always think about it this way. We're not just trying to kill the bugs, we're trying to fix the immune system because the immune system has to deal with these bugs. And I think it's
Mhm.
an important point to make because, here in New York, I'm in Westchester County. This is the home of Lyme disease, essentially. We are very close to Lyme, Connecticut. And if I pulled 50 people off the street, I look out my window and I see the highway right there, and I'm like, okay, I'm gonna get 50 people in here. I'm gonna run T-Lab on them right now. I suspect 90% or more are gonna have one or more of those infections. Not all these people have symptoms. Some of them are very healthy. Some of them have symptoms, but are going to conventional doctors or practitioners who don't understand, right? So they may have migraines. They may have joint pain. They go to the orthopedist for this. They go to the neurologist for that. So they may very well have symptoms, but maybe it's mild and they're managing with the people they're seeing. But there are also going to be people who have no symptoms. And I have families like that where I have several people in that family who are very, very sick. And then I might have like a father or mother who says, everyone in the family has it. I want to be tested, but I feel fine. And we test them and they have everything, but their immune system is different, right? So my goal is always to figure out how can we help the patient deal with those infections if we can't kill at all. These infections are going to persist in our bodies, what can we do with the terrain that the bugs are living in? And so that's where we rely on other modalities. So we use something called SOT a lot, supportive oligonucleotide technique. We combine that very often with herbs or other immune modulators, let's say. SOT is a way of targeting the bug very, very specifically. Basically, like it's a protein that's created that matches let's say, the protein of the Lyme that you have. The lab creates it that way. That protein goes in, binds to that DNA, and it starts to shut down the replication of the organism. Over time, that kills them, but the immune system has to kick in to take over too. So to me, it's a nice treatment because it allows the body and the immune system to work in tandem with what you're doing. SOT therapy has been an absolute game changer. I started doing it in 2019, and we've done hundreds, I don't know, 500, 600. I'm sure more than that at this point. Sure, it's not like everything else we do. It's not going to help every single person. We have outliers, but it has allowed us to heal people in ways that we couldn't with antibiotics. So I think it's exciting. But again, with like everything, nothing's perfect. Nothing's perfect for everyone, right? And the other things we rely on are things like ozone therapy. Ozone is really helpful particularly, I think, for Bartonella and Babesia, because ozone is super oxygen. The red blood cells are trying to sort of pick up that oxygen. And I think it's helping to kick off the Babesi and Bartonella out of the red cells. And then ozone is a disinfectant. So I think then it's disinfecting and killing whatever's in the blood. So I think ozone is a really nice addition, sometimes used in combination with other things that we're using. There are other IVs that we use that also support the cell, the mitochondria. There are just so many tools that we have now. I look back 5 years, 10 years, it's like a different world. I do a lot of herbs. I'm trying to think what else. And then now we have plasmapheresis. We have therapeutic plasma exchange, which I know
Mhm.
you do too. And this has been
Yep.
the most exciting thing for us because we don't have the data yet. It's too soon. But my hope is that TPE is going to allow us to remove some of the infections from the blood, pull out the garbage, allow the immune system to reset, and maybe help the body to heal. And then maybe combine it with SOT, meaning that after you've done a series of TPEs and you've cleaned things out, then you go in and you do SOTs. So
Yeah.
these are things that we're working on here in the clinic, and we're really excited about the potential.
Amazing. Even, we'll often do after TPE, we'll often do IVIG for a similar
Yeah,
reason. It's not
we
nearly as
do too.
targeted as these,
Yeah,
but it's that component of like now we're trying to shift what remains.
exactly.
So amazing. Tanya, amazing. Amazing, amazing. So we only have a short time today. We've just got a few minutes left. Tell us a little bit about ILADs and kind of, until I met you, I thought of ILADs as Lyme, but it's associated diseases. So tell us a little bit about ILADs and when the annual conference is, et cetera.
So I'm on the board of directors. It's an amazing organization with the mission to educate, people, educate providers to help more patients. We have our annual conference in San Antonio, October 7th through 10th, I believe. It's going to be an amazing lineup. I'm on the program committee, so I've been working on the conference as well and putting it together with some colleagues who are all amazing. And our goal this year has been really to try to understand the terrain even more, not just the bugs. So yes, there were definitely talks this year on, Lyme and Bartonella and Babesi and things like that, but there's a lot of focus on ways to support the body, the immune system, to help people basically live with chronic infection that will always be there, but maybe in a very, low level that is not noticeable, right? That's the key. Doesn't matter if it's hiding and you're feeling great. So the focus this year is really, really great. We have a whole session on IV therapy.
Mm,
Have Anderson doing
mhm.
a huge block on different IVs. We have a number of other speakers. So on IV therapies, not IV antibiotics, IV real like different
Yep.
modalities. I think someone's talking on plasmapheresis as well. We have talks on. I'm doing a talk. I'm doing actually 4 talks, which I
Mhm.
think I overcommitted myself.
That's perfect.
Um, I'm doing a talk with Claudia Miller,
Mhm.
who is the queen of tilt. Dr.
Uh-huh.
Miller is in San Antonio, and so I'm excited to have her. We're doing a joint presentation on toxicant-induced loss of tolerance, how to evaluate patients for chemical sensitivity, and she has a great tool that she uses to evaluate patients. So we have that we're going to be doing, and I'm giving a talk on GLP-1s and inflammation and helping the immune system. So what's really exciting about where our organization is going is this understanding that, yes, we need to understand these organisms, but we need to understand more what the organisms are doing within our bodies and how our bodies are going to fight it. And so this is like a really exciting time. So I can't wait. So you're going to come this
Yay.
year, right, Jillian? You're going to come?
I would like to. So I gotta look at my dates, but I would love
Yeah.
to. Be great to hang out. I know that we were talking, this podcast is a little bit short because the amount of time we had, we really wanted to just talk about lives. You're just a fantastic person, Tanya, and I thanks so much for your time in doing this. You're just such a wealth of information and such a fun, kind person. So I always appreciate hanging out with you.
You, I
Want to find out more, I just want to drive, I always just want to drive people to see you if they need you. So ILADS is ILADS.org. And you
yeah.
can find out more about Tanya and her clinic at Tanya, Tania, Dempsey, DEMPSEY.com. So drtanyadempsey.com and ilads.org. And we love that you've joined us today to discuss how to make our whole world medicine. We rise or fall together and are committed to sharing knowledge and insight that empower us and our communities towards greater health. Thank you for listening to the Nervata podcast for complex health, and we will see you next time.